Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. Hi everyone, and Happy New Year. I apologize for my brief hiatus. However, the pandemic has definitely played a significant part in my inability to be on my podcast on a regular basis. I am hoping that that is in the past, and moving forward, I will be continuing to be able to give you insight and information associated with the identification and treatment of a tongue thrust via myofunctional therapy. Today, in particular, I wanted to review what we had spoken about what I had spoken about in the weeks leading up to my hiatus, which spoke so much about a patient's history and how important that history is when it comes to identifying and diagnosing a tongue thrust, but also impact that history has on some of the referrals that we may make prior to the initiation of a therapy regimen. I want to use today's podcast to discuss identification of an anterior tongue tie, what it looks like, and what the steps are to take in the event that you suspect your child does have an anterior tongue tie. So where I left off before I took my hiatus is we were discussing so much about how important it is for us as a speech-language pathologist, but specifically as a myofunctional therapist, to get a very detailed case history and background history, developmental history. When I'm training our staff and educating and lecturing to other medical professionals, I always say to them that history should not be a mystery. Yes, as a speech-language pathologist, I tend to make everything rhyme. However, it is true. Your patient's history should not be a mystery, because what has happened in their past from prior to, during pregnancy, to delivery, to infancy and feeding, all of those symptoms or diagnoses can all play a factor when it comes to making a diagnosis and identifying and recognizing compounding conditions, as well as in terms of making referrals. So once we do take our very detailed case history and we do our evaluation and probe with questions, it's important that at that point we make recommendations based on the concerns that we have regarding our patient being successful with therapy. And if there's anything that we're seeing or any history that points us perhaps in a direction that would negatively impact a patient's success or limit their ability to be successful at achieving the different goals associated with myofunctional therapy. One question or one area that we tend to make a plethora of referrals has to do with the lingual freedom. And the lingual freedom, if you can click your tongue, or if you stick your tongue up and touch the back of your front teeth, there is a little thin piece of membrane under your tongue, and that is your lingual freedom. Everyone's lingual freedom is different. It is a short lingual freedom is something that is hereditary, so it is common to see a short lingual freedom with a child and their parents and their grandparents, and it can date and continue as far back as we tend to look, or how often you tend to look in your ancestors or your family's mouths. But for us, it's very common for it to be hereditary. There are also different types of lingual freedom. different types of lingual frenums that require intervention. For example, some individuals have a short lingual frenum that limits their tongue tip from moving and being mobile, and literally holds the tip of the tongue down to the gums behind the bottom, lower central incisors, or behind the bottom teeth. Those shortened frenums typically result in a heart-shaped tongue if your patient was to stick out their tongue. It also is something that is usually recognized pretty early by the pediatrician or a parent, because those type of short frenums often interfere with latching and sucking, and can cause digestive issues, as well as pain when breastfeeding. So those difficulties are often, or I should say that short frenum is often identified pretty young, especially if it is having an effect on the parent, causing, say, mastitis, a failure to thrive, gas, hiccups, burping, upset stomach, all of those things. All of those things would be symptoms of perhaps a shortened frenum, and perhaps require intervention. Oftentimes, when a parent has difficulty latching or has difficulty with breastfeeding, they will consult with a lactation consultant. And it is not uncommon for that lactation consultant to make a referral to an oral surgeon to have that frenum assessed for potential frenectomy. Furthermore, it's also something that the pediatrician may identify during their well visits, especially as they're taking their weight and seeing, you're discussing with them how they're doing with regards to acquiring nutrition, thriving, digestion, even discomfort. So it's when we have a patient or a infant that has a short frenum, it often results in a perpetual tongue thrust, which is not uncommon with infants. However, that placement of the tongue and its restriction does allow an increased amount of air into the abdomen. That increased amount of air will cause the gassiness and discomfort, even some GERD, gastroesophageal reflux disease. It also could result in symptoms associated with colic. So in those well visits and those well checkups, a pediatrician will often look at that, but it is also important as a parent for you to be looking at that, as a professional to be always checking the frenum. I think I have mentioned this before, but way back in the day, it was something that was checked in the nurseries post-delivery by the nurses, and if a frenum was short, a nurse would use their fingernail and sever the frenum of the babies in the nursery. Clearly due to sanitary reasons and the advance in medicine, that is not something that still happens. However, we are in a world of reactive medicine, not proactive medicine. So it is important as a parent or a practitioner to be able to assess the frenum, look to see or question whether you feel the frenum is too short and could be, in fact, impacting your child's development in any way, shape, or form. Now, I know there is something called mother's intuition, and I believe in that wholeheartedly. If you are uncomfortable with the recommendation or the opinion regarding your child's frenum being too short or its impact on its growth, your child's growth and development, don't hesitate to seek a second or third opinion. Knowledge is power. And as a parent, if that in your gut, it's telling you that could be impacting their growth and development, by all means, it doesn't hurt to get more information, to seek additional opinions. The other thing is that when it comes to an anterior tongue tie or that short frenum that restricts the tongue tip, The long term, even if it's not affecting their diet and their nutrition and their ability to thrive, it could long term affect their overall occlusion and result in dental issues. It could also result in articulation or speech issues. The tip of your tongue is responsible for the majority of the sounds in the English language. For example, the T sound is in Thomas, the D sound is in daddy, the N sound is in no, the L sound is in lollipop, the S sound is in Sam, the Z sound is in zebra. The list goes on and on. It also is where the initiation of your adult swallow happens, or your adult swallow occurs. So if your tongue tip is unable to make contact with the alveolar ridge and the palate, it will impact your child or your patient's ability to develop the mature swallow, but it will also impact the shape of their oral cavity and shape of their palate, as well as their overall occlusion, thus resulting in the need for potential palate expansion or orthodonture. Another area that is often not considered when looking at a short anterior tongue tie or short lingual frenum at the tongue tip is the impact that it has on a patient's ability to open and close their mouth and dissociate the structures of their mouth. So are they able to elevate their tongue tip while keeping their mouth open, or does that elevation or the movement of the tongue require the movement or the compensation of the jaw? For patients that typically are tongue-tied, it is not uncommon to see them have symptoms associated with temporomandibular joint disorder, have difficulties with grating their jaw, which will impact chewing, as well as the production of certain sounds because they're unable to mobilize their tongue and their jaw separately. Now, if it's not addressed, it will have a long-term effect on the jaw and the temporomandibular joint, because once the frenum, if it is released, and once it's released, whatever symptoms that are present, they do not go away. It just, our hope is as we're stretching and improving their range of motion, that their symptoms associated with their TMJ will lessen. So just recapping some of what I had mentioned today during my podcast is, if you suspect your child is tongue-tied or has an anterior tongue tie, some of the things that you can ask your child to do is stick out their tongue. Does their tongue tip appear dimpled or heart-shaped? You can have your child open their mouth and take your finger and swipe it underneath the tongue and see if you feel any restriction. 3, you can observe it. You can have your child open their mouth and see if you can actually see an attachment of the tongue tip to between the lower dentition or attached to the gums behind the lower dentition or the lower central incisors, and make that observation. 4, if your child is an infant and they're having difficulties latching, thriving, acquiring nutrition, colic, gassiness, reflux, all of those could be symptomatic of a short lingual frenum and is worth asking or assessing it yourself and asking your pediatrician. Something else to be considered if a patient or an infant is having difficulties latching or nursing, or causing the parent to have mastitis or infections in the breast, that could be a sign of a short lingual frenum, an anterior tongue tie and a short lingual frenum. And last and most important is that If you feel as a parent or a practitioner that the frenum is too short and impacting your child in some way, shape, or form, or your patient in one way, shape, or form, it never hurts to get more than one opinion. Especially because different practitioners or different medical providers will look at the range of motion of a tongue tip based on that area of specialty. So if it's a pediatrician, they're going to look at it from an nutrition standpoint, and especially if it's not affecting your child's nutrition, then a dentist or orthodontist may look at it from the perspective of how it's affecting the oral cavity and the development of the teeth. Where a speech language pathologist is going to look at it from what the range of motion is and how well they're able to articulate and swallow. And the oral surgeon, I have such a good feeling about in terms of making my recommendations regarding a frenectomy, or assess a patient for whether a frenectomy is necessary, just because I think many times and many oral surgeons will take everything into consideration, which is important because what you're seeing now as a parent or practitioner may just be the first sign associated with their short anterior tongue tie or their short lingual frenum, and there may be more issues coming down the road or more issues that will arise secondary to that shortened frenum. I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech language pathology and myofunctional therapy.